Good evening, everyone. I welcome you to this another session. It is my proud pleasure to introduce Dr. Pranavendranath, who is a highly motivated physician with expertise in general medicine and cardiology. He is dedicated to treating chronic conditions like diabetes and is experienced in managing complex cases like we had in COVID-19. He possesses a meticulous approach and a proven track record of diagnosing and treating various illnesses. Notably, he has experience with critical care and mechanically ventilated patients. So today, he will be talking about diabetic nephropathy in Indian scenario. Over to you, Dr. Pranavendra.
Thank you, sir. Thank you for the myself, Dr. Pranavendranath. I'm here to give a talk regarding a small talk, concise talk regarding the prevalence of diabetic nephropathy in India. So, where it all began. So, coming to the health sector, where it all began. So, diabetes in India, coming to the prevalence, is about 9.6% among the adults who age 20 or more, and exclusively India is filled up with all kinds of chronic illnesses, such as diabetes, hypertension, and where the diabetes possesses a major role and competing with hypertension. And here comes like number of people with diabetes in India is the second highest in the world. And in India, 1 in 11 adults is living with diabetes, and over 53.1% of the adults living with diabetes are undiagnosed. Overall world, if you take the overall world percent, it is over like 70 to 80% of the people are in diabetic stage who are undiagnosed. Among them are 20%. So approx 50% are in diagnosed state, and likely another 30 to 40% are undiagnosed. And here comes the small talk regarding nephropathy, diabetic nephropathy, and oral diabetic kidney disease, where it can be divided into two states, like microalbuminuria and macroalbuminuria. So urine albumin excretion is, if at all, greater than 20 grams per minute and less than 199 microgram per minute. It is micro, and coming to macro, it's greater than or equal to 200 mics per minute. So, one third of the diabetic patients showed microalbuminuria after 15 years of disease duration, and less than half developed real nephropathy. So, DKD is the primary single cause of end-stage renal kidney, that is DKD. So, coming to the actual prevalence of diabetic nephropathy in India, according to IDF 2021, the number of people affected worldwide has increased by 46% to approximately 783 million. So in India, it contributes major sector of diabetic patients and who are diagnosed and underdiagnosed. And registry data suggests that diabetic accounts of 45% of the cases among end-stage renal disease patients receiving renal replacement therapy. And whereas the study on August 1st, 2007 revealed prevalence and high risk factors diabetic nephropathy in urban South Indian population, and it mostly it's in the Chennai. Here, the prevalence of overt nephropathy and microalbuminuria was 2.2 and 26.9% respectively. So during the diabetes duration of the diabetes, the HbA1c value and systolic blood pressure were common risk factors found out for the overt nephropathy and microalbuminuria. So stages of diabetic kidney disease, where we can see the stages like hyperfiltration and silent kidney disease, incipient and overt and end-stage renal disease. So here, what happens is actually it starts with the glomerular hyperfiltration and hypertrophy, and by the end of end-stage renal kidneys, the glomerular part or the diffuse glomerular sclerosis will be occurring along with albuminuria. First, normal albumin, and that is up to the overt stage. Later on, it decrease albumin. GFR is slightly, means sequential decrease of GFR also we can see, and the hypertension. Hypertension we can be accompanying later in the following slides. So this is the pathophysiology of diabetic nephropathy, where the patient having the hyperglycemia state and with renal hemodynamic changes and activation of RAS system and ischemia and inflammatory changes, oxidative stress. All these accompanies for the rise in oxidative stress hormones and enzymes, everything, and which contributes to three mechanic actions. Whereas like glomerular hypertrophy and sclerosis, podocyte injury, and tubulointestinal fibrosis, accompanying to mesangial cell expansion and contributing to diabetic kidney disease, all the three. So here comes the therapeutic strategies for diabetic management, where it, according to new studies and guidelines and articles, literature. So early initiation of the combination therapy is an approach to achieve glycemic goals as correct earlier and delay the deterioration of glycemic control with possible better prevention of beta cell function. So here, what novel medication therapies is used with diet and exercise. That is lifestyle modification to control high blood pressure in adults with type 2 diabetes, and with drugs, novel medication combination drugs we can take up with DPP4 inhibitors like sitagliptin, saxagliptin, linagliptin, and SGL2 inhibitors like dapagliflozin, empagliflozin, canagliflozin, and GLP-1 receptor analogs, that is mostly like semaglutide, liraglutide, etc. So a combination of SGL2 inhibitor plus DPP4 inhibitor is suitable for option for Indian type 2 diabetic patient and the following reasons: because it is safer, rapid action, and sustained glycemic control. Good. Improves both insulin resistance and beta cell function. Yes. Helps reduce body weight and body pressure. Exactly. Reduces pill burden and overall cost effectiveness. So here's a smart combination which includes SGL2 inhibitor and DPP4 inhibitor, which constitute of various functions both individually and actions on individual organs like kidney, pancreas, cardiovascular, and gut. So basically, Indian population are most of the patients with diabetes are uncontrolled. So we tend to start in the combination therapy as SGL2 inhibitor plus DPP4, and it's a good choice for the patients who are having the comorbidities like metabolic syndrome and uncontrolled sugars and hypertensive, obese, all kinds of metabolic syndrome, and including the diabetic nephropathy. Combination drug tends to be in good use nowadays. So yeah, DAPS study. So here the FT therapy of dapagliflozin, sitagliptin was effective in improving blood glucose control among the diabetic patients in 3 months. It is effective alternative treatment option for the diabetic patients with adequate glycemic control. So you can see here the change in the fasting plasma glucose and postprandial glucose. Uh, on the graph, the blue graph indicates the fasting, and the green indicates the postprandial. So tends to in the during the course of 3 months, the graph line tends to be in downsloping, and the change in the HbA1c levels. It is the baseline HbA1c level is 8.9, and by the end of the third month or 12 weeks, it is like 7.2. It is a drastic change in the glycemic control. So benefits of SGLT2 inhibitor in diabetic nephropathy, and by as mentioned here, the potential mechanisms of SGLT2 inhibitor induced nephroprotection. What are those? And it is a glucose lowering dependent mechanism, and it also got decrease in blood pressure, body weight, serum uric acid level, and decreases the hyperfiltration via tubular-glomerular balance, and decrease hypoxia due to shift in fuel consumption. And as you can see the graphs also, the difference between the placebo and the dapagliflozin effect, and the other thing is renal specific composite outcome, which is good with dapagliflozin as we suggest here. So here the significantly reduced lower risk of composite of sustained decline in the estimated GFR of the at least 50% and end-stage renal disease or death from renal cause. So, along with the diabetes, it is more profoundly used with heart failure patients also. Benefits coming to DPP4 inhibitor in diabetic nephropathy, and it improves kidneys function, corrected renal histopathology by decreasing, urea and decreasing urine albumin creatinine ratio, and increases the creatinine clearance, and by that way it improves the kidney function, protective function, and renal histopathology is decreasing interstitial fibrosis and glomerular sclerosis. And DPP4 it also activates the GLP-1, and yeah, by that way it also substrate means it also prolongs the action of BNP and peptide, everything. By this, SITA significantly reduced diabetic kidney disease by inhibiting the kidney index and attenuating 24-hour urine protein. reducing the BUN and serum creatine, inhibiting progressive renal fibrosis, and increasing extracellular matrix, including collagen 4 and fibronectin. So, protective function, renoprotective function is of DPP4. It mainly shows good renoprotective by inhibiting the progressive renal fibrosis, and decreases the glucose levels, increases cardioprotection, and decreases oxidative stress, and decreases the renal inflammatory process also. So hereby I conclude my session of small concise talk regarding the prevalence of diabetic nephropathy in India. Uh, I request Dr. Masuji sir to continue the session, and if at all any questions or queries, just please go on.
Thank you, Dr. Pranav. It was a nice talk.
Yes, sir.
You nicely summarized this complex topic of nephropathy. There was a time when we would say that in a patient of diabetic retinopathy, you find this much of protein, then we call it diabetic nephropathy. So it means that first you have to have a diabetic retinopathy. But
Yes.
presently, we see so many cases where we find nephropathy to start with, or there's no retinopathy, but there is nephropathy. So you made it very simple and very nicely discussed. Thank you very much.
Thank you.
Uh, there are some questions. Can we go ahead?
Yeah, please, sir.
So though you mentioned it briefly, but we would like to for the audience.
Yes, sir.
What are the
Sure.
primary risk factors for diabetic nephropathy in Indian diabetes patients?
So diabetic
Factors.
nephropathy, so we tend to have risk factors like hypertension, uncontrolled sugars initially, hypertension, obesity, and cholesterol, hypercholesterolemia, dyslipidemia. It all constitute, and mostly majorly in India, we tend to have low sedentary lifestyle. These
Right.
are the main risk factors for what we go diabetic nephropathy constitutes.
Right. Thank you. The another question is how does the presence of conditions like hypertension and cardiovascular disease affect the progression and care of diabetic nephropathy in Indian patients?
So basically, the both hypertension and diabetes are chronic illnesses, as you know, and it tends to start at any point, some point of lifetime in individuals at aging, even in young people. Mostly, we tend to see in young people nowadays. And the main thing we found out, like it is hyperfiltration. So hyperfiltration of the renal, urine. So this we tend to found in most of the patients along with hypertension and diabetes, and undiagnosed diabetes also constitution to the nephropathy. As you said, the retinopathy is nowadays difficult to identify in the people with nephropathy. So we tend to found this is the main reason culprit causing means leading to the diabetic nephropathy. The people.
Thank you. Next question is what are the latest diagnostic guidelines or tools for early detection of nephropathy in Indian clinical setting? Diagnostic tools and
Yeah.
guidelines.
Coming to latest guidance tools which physicians and endocrinologists, diabetologists use tend to use. Previously, we use for urine dip test. So nowadays we are going with urine spot urine albumin creatine ratio, and
Yes.
it is good actually. We can sort out. We can actually divide the patients in the diabetic nephropathy patients from uncontrolled diabetic patient or hypertensive. Like we tend to use few tools and few guidelines to differentiate that stage of diabetic nephropathy, including GFR. And the first one, with anyone coming to the clinician or clinic or anything, we tend to go for urine albumin creatine ratio, and it actually gives a good result in diagnosing, differentiating and diagnosing also. So GFR along with albumin, so we can tend to consider like microalbuminuria or macroalbuminuria as well.
What is the normal ACR albumin creatine ratio? And when
Yeah.
you would say there is
Yes, sir.
microproteinuria,
Urine ACR, we tend to take the value of 17 or less, generally in men, generally in men. And if at all it crosses more than 20 or 25 in females, that is also acceptable nowadays, and should not cross more than 29 probably. and some guidelines say it is more than 30 also. But we tend to follow the as much as the, because the architecture of the human body or the diabetic control of the human body depends on various genetics and everything. So we tend to take about range, the range value. Based upon that, we tend to classify each and every person into the stage. So coming to GFR value, we tend to start, or we tend to go for the drug therapy, means diabetic therapy, if at all, and that is also mainly SGLT2 inhibitors. And if at all he is possessing other comorbs like hypertension or heart failure related things as well. So we tend to start SGLT2 inhibitors in him or her, the patient, so that he can get modified, means renal protective action along with cardio protective action. So coming to, means starting from the urine ACR, we tend to go to the level that extent we can treat the patient in certain level based upon the age and this progression, depending
Right.
upon also HbA1c levels.
The next question is what evidence based methods can general physicians use to screen diabetic patients for nephropathy during routine examination effectively? Because many of the patients may have nephropathy to start with the moment they come with diabetes.
So basically, we tend to take the history clearly as much as possible, because some of the patients coming from the rural, or many of them are unemployed, illiterate, something. So we tend to guide them in a proper way, starting with good therapy and starting with basic need of investigations. The investigations possess a greater and major role in treating diabetes in India. So most of the people will never go for any of the investigations. Any of the investigation. This is well-known fact. But the clinician or the endocrinologist or the dietitian who is treating the patient, who is actually talking to the patient, should guide them in a such a way that investigations in a diabetic profile patient are essential. So first thing we'll go with the fasting postprandial HbA1c levels and urine protein ratio, spot urine, or we can go for 24 hours urine protein also. So these all tends to, including the GFR, calculating the GFR, this all tends to clearly understand what exactly diabetes is doing to his kidney or his heart, and any other complications are arising.
Right. Thank you. Next question is what are the main challenges endocrinologists and diabetologists face in managing diabetic nephropathy cases in India, and how can they be tackled?
The first thing is most of the patient never understand what actually the treating clinician wants from them. They never follow. First complaint from each and every patient, majorly what we found out is they never follow the drugs, they never follow the diet, they never follow the lifestyle modifications, and they never ever follow the follow-ups. They never come to the follow-ups regularly. So all four contributes to loss of either leading to this uncontrolled sugars, or leading to this, vascular complications, and leading to completely end-stage renal disease. Some patients also tends to say, I tend to see in the starting phase, and I also saw them in the end-stage renal disease taking renal replacement therapy. So these features mainly contribute those things.
Right. So, what specific dietary measures or have specific dietary or lifestyle changes shown effectiveness in slowing or preventing diabetic nephropathy progression among patients? So, dietary and lifestyle changes that have been shown to be effective in retarding the progress.
Hmm. So basically, what dietary advice I would prefer to give is, uh, first control your sugars with drugs. Basically, control, do lifestyle modification, like go for an aerobic exercise, like hardly 150 minutes per week as guidelines say, preferably. Like make your blood pressure controlled every time, all the time. If at all needed, go for the drugs. And most main thing in India what we face is salt intake is very much high in India. So with that, we patients got increased with hypertensive changes, both vasculature changes, micro and macrovasculature changes, along with the diabetes. So I would prefer to say them to reduce the salt intake by hardly 3 to 4 grams per day, if at all they are not hypertensive, or less than 3 grams per day if at all they are hypertensive. Along with that, I would prefer to take would prefer them to take omega-3 fatty acid supplements as well,
Right.
and make the HDL level little higher than 50.
Okay. So, are there any over-the-counter medications or supplements that diabetic patients should avoid due to potential kidney health risks? Because there's a common tendency among patients not to go for supplements, to go for tonics.
So what we face, means clinicians generally face, was if at all a patient is diabetic, he would think he will be in the diabetic phase, that to uncontrolled phase to lifelong, and there is no other go for him to completely cure. So in search of complete cure, these patients are scrutinized to means they act upon single a narrow view vision, and they'll go to other modalities like going to Ayurveda, Unani, and so etc etc. So what happens is, once we keep them on one drug, they would choose to go on other drug as well. It means combining with the same what we kept in the allopathy. So what
Right.
happens is, by relatives or somebody has convinced them to take that particular drug, which affect they don't know, which that also affects the diabetic profile as well. So I would prefer to lose some chromium content, or and also the niacin content as well. These vitamin, niacin, everything tend to possess alteration in HbA1c level when you take the drug which already prescribed the clinician. So I would prefer not to go for those things. And also in India, we got n number of herbs, so which also possess, which till date could not be known to 100%. We cannot say those drugs are harmful to the diabetic patient, but in terms of drugs which we are prescribing them, they may have very much like the moderate to mild to moderate effect on the drugs as well in reducing HbA1c level. So in the particular stage, the patient should always tend to stick on to the clinician alone. He or she should not take another advice at all when following allopathy.
And coming to drugs we use commonly in diabetes, especially when you have kidney disease. So, how do SGLT2 inhibitors and DPP4 inhibitors differ in their mechanism of action and benefit for diabetic nephropathy patients? So,
Yeah,
SGLT2
SGL2
inhibitors
inhibitors.
versus gliptins.
So SGL2 inhibitors are like mostly they're lowering the glycemic control, causing glycosuria. So that is very much essential right now, and also they are lowering the systolic pressure. So it is very much good, and it is it's an alternative for diuretic as well. We prescribe for heart failure patient as a diuretic alternative to diuretic, and the guidelines also showed it's a good result, uh, starting in the initial stage in the diabetic nephropathy as well as with cardio renal protection action. Coming to DPP4 inhibitors, they work on different action by controlling or increasing the incretin secretions. So depending upon the action, both these are combined together, will have absolute glycemic control as well, and lowering the blood glucose, blood sugar, blood pressure levels, and maintaining the body weight as well.
So, are there specific patient groups such as those with certain comorbidities or kidney function issues for whom combination therapy with SGLT2 inhibitors and gliptins is particularly recommended or discouraged?
I would say it differs from patient to patient, and what stage is being now, sir. Basically, we tend to start in the novel therapeutic drugs, SGLT2 inhibitors plus DPP4 inhibitors naturally. But what happens is, patient depending upon the patient and his choice with either he's having any other comorbs, and I tend to prefer along patient. It differs actually patient to patient. So that's it. We cannot straight away go to each and every patient to take them the pill, either it is having they're having a comorbs or not.
Thank you. Last question. You know, this is a digital age and we talk about everything digital. And, because of COVID, there are a lot of problems, but there was some one advantages that we started using digital applications and telemedicine. So, how do telemedicine and digital health technologies contribute to early detection and management of diabetic nephropathy, especially considering India's diverse healthcare landscapes? The use of telemedicine and digital health technologies in detection and management of diabetic nephropathy.
So, coming to telemedicine in diabetes, it has given a profound and immense knowledge to each and every citizen of India or around the world, I say. So, what happens exactly in India? The literacy rate, we must go to the literacy rate as well. Even though each and every person having the smartphone, they cannot access the required information from the phone or the app which we provide or someone. So coming to telemedicine in diabetes, person with undiagnosed diabetes, he tend to check the symptoms and signs on the net. He tend to call the concerned doctor or clinician. He meet the clinician, and it's a good choice opting a telemedicine, but proper channel through proper channel. It should follow some rules, and it should also have some enlightenment to the people. Like we tend to go with diabetes care, so the care should be taken away to the concerned particular clinician alone. If at all we are just giving out the rules like randomly to the patients, they would not understand, and they would think everything is because of diabetes. There are other immense chronic illnesses as well like diabetes, so we should give according to the what patient or the person needed. That information should be given through the telemedicine, and by modulating or motivating the patient to reach the clinician to find out the stage or the present situation of the diabetic profile in that patient, or is actually having other chronic illnesses.
Thank you, Dr. Pranav. It was nice. You talked about nicely about why this prevalence of diabetic nephropathy in India. What are the challenges? How do we detect it? What drugs we should prefer? What drugs we should avoid? And you give a broad outline how we can use telemedicine, digital technologies